To everyone here, thank you for being here. Appreciate your time in attending the meeting. At this time, we will allow for anyone to disclose a conflict of interest. Conflict of interest that exists? Seeing none, we will move to item 3, which is our mission statement. Dr. Fisher, would you be kind enough to read our mission statement?
The mission statement to improve the health and wellness of Nashville by providing equitable access to coordinated patient-centered care, supporting tomorrow's caregivers, and translating science into clinical practice. NG's vision is leader in exceptional community health care, one neighbor at a time.
Thank you very much. Ms. Lesser, is there any public comment?
No, ma'am, there are none.
Thank you. Next item on the agenda is the minutes. Has everyone had an opportunity to review the minutes? If there's no additions or deletions or amendments, I would ask for a motion to approve.
So moved.
Is there a second?
Second.
Okay, any discussion? All in favor? Aye, motion passes. Who is second? Thank you. All right, next, before we move on to our old business and the PSA update, I'd like to start out and just welcome our 2 newest members to our board of directors, Dr. Scott and Alfonso Harvey. We are excited to have you. I've heard about each of you individually. Obviously, it's my first time getting to meet you, and look forward to the opportunity. I know our whole board does in working with you and having 2 other slots. Thank you already for being at our finance committee, showing up strong for our finance group. So I'd like to just take maybe just a couple seconds here and let each of you introduce yourselves.
Shane Scott, I'm the senior pastor of the First Baptist Church, Capitol Hill, where we have served this community for nearly 160 years. Madam Chair, at a certain point, I'm going to excuse myself. It's my wife's birthday.
Good evening. I'm Alfonso Harvey, 30-year resident of Nashville. Came here to Vanderbilt and played football. I am a maternal health advocate. I believe in Nashville General's role in this North Nashville community. I'm excited to be here to serve.
Thank you very much. We look forward to getting to know you both better as we progress. So thank you for your time. And a happy birthday to your wife. Glad you have your priorities straight. That might be a problem later on for you if you get home late. Next item on the agenda is old business, which is a PSA update. Mr. Esquivel, thank you.
Thank you, Madam Chair. Well, this is wrapping up something that has been in process for several months, and I'm reminded with new board members to maybe go back a little bit in process to understand what we're doing. For several years, the relationship between Meharry Medical College and the hospital, which ought to have been subject to written agreement for a variety of reasons, was not. And so the board actually received a letter several months ago from legal counsel saying this needed to be an imperative, and we could no longer function in the relationship that we have with Meharry without a formal agreement. Again, for a variety of reasons, some of which are laws that are in place that need this type of formal arrangement in order to have legal compliance. And very pleased to report that through the diligent effort of the leadership team, both at the hospital and Meharry, the terms of that agreement were worked out over the course of diligent meetings that I attended as an observer since March or so. No, it already preceded that. It was in February. And that most recently, the agreement has been thoroughly vetted by legal counsel, both legal counsel on Meharry's side, our outside legal counsel that we have direct contract with, and Metro government hired law firm to independently and on behalf of Metro's interest in this agreement, provide legal counsel. So my understanding is that that has been completed. The board, every member of the board should have received both a copy of the agreement itself and a summary from our outside counsel at Spencer Fane. And it's a great thing to celebrate. And any hard questions, I will turn over to Dr. Elders now. If the board has comments or questions or wants to talk about the agreement, and also if Dr. Elders or others want to make further comment on it.
I have a couple of questions. First of all, I want to reiterate what you said, and that this is a wonderful document to receive. It's been long. We waited for this a long time, and it certainly helps the hospital, but I think it is even better for Meharry and the staffing of the hospital. But there were a couple of things that I had questions on. One was who appoints the chairs of the division, because there may be some disparity in different levels. So on page 10 of the document, it says, in consideration for Meharry supplying NGH with physicians to serve as appointed chiefs. So that kind of says that Nashville General appoints the chiefs, but then on page 20, it says Nashville General, or that Nashville General will select the chiefs from members of the medical staff who hold faculty appointments at Meharry. So do we select the chiefs of services, or does Meharry?
So, Dr. Miller, to answer your question, what we have developed is a joint kind of hire committee that will be chaired by Dr. Bullock and the dean, Dr. Harris Haywood, and we are partnering to make those decisions collaboratively. So we will not be making those decisions in silo, and I believe after the signature of this and as we continue to foster that relationship, it will open the avenue for continued discussion on those positions.
And then the other thing was with regards to reimbursement, that it looks like that Meharry will bill for services, whether it's Medicare, Medicaid, or private insurance, for those patients that are uninsured. Will reimburse them at a rate of 125% of Medicare. Is that 125%, is that a historic number?
Yes, sir. That 125% is a historic number that was dated in the previous versions of the PSA, and we did not change that during this time. Okay. But it's a long history, yes, sir.
And then the other thing is, who is responsible for covering uncollected or denied claims? So part of this says that we will reimburse Meharry for denied claims, and then it also says that we will not reimburse for denied claims. And I think that the two portions for that,
which page?
I've got to find it here. Oh, and on page 11, Meharry will take responsibility for collecting from insured patients its professional fees for clinical services, and Nashville General will have no responsibility for those charges. And then, where did you? This is page 11 of the.
What's that at the very bottom?
This is page 11. It's item number 3. And then elsewhere, and then in the compensation process on page 9, it says Nashville General will reimburse Meharry for the amounts Meharry's unable to collect. So those seem to be in conflict. That's in compensation processes.
If I can, I think I'm answering your question, but, it talks about eligible persons. It also talks about professional services that are not considered charity care. So I think there's a couple of distinctions in that. Can you restate the question that you're seeking the answer for?
So I think that in compensation processes on page 9, it says Nashville General will reimburse Meharry for the amounts Meharry is unable to collect. And so that would apply, I think, like to third-party payers, insurance companies.
Well, we use a tool, ESI, I believe, and maybe Dr. Blackledge, if you jump in as well, but we use a tool, ESI, for our uninsured population. And so if there's a pending application for either Medicare or TennCare, it goes both ways. So there's another portion
Right.
On a page that it goes both ways. So if they can't collect, we will pay them based on the uninsured charity program.
Correct.
If they can collect or they come back and are able to get those funds, they reimburse us for those funds. So it's kind of equal.
But I think that this is applying kind of in this context that Meharry will undertake good faith, reasonable, diligent efforts to bill and collect fees for services that are provided to patients. Nashville General will reimburse Meharry for the amounts Meharry's unable to collect.
I would say that the part that you just read refers to such patients, which are self-pay patients.
Yeah.
So I think the distinction between these two provisions is that the D3 that you pointed to are insured patients.
Okay.
So
So that
Meharry
would-
is solely responsible where a patient is insured.
Okay.
And then the arrangement that Dr. Elders just referred to is for
Uninsured.
self-pay
Okay.
patients,
Then
which
that's,
are,
then that's all
I think that's the
consistent.
difference.
Okay.
Does that make sense?
Yeah, that makes
Okay.
sense. Okay.
And I would like to add for the committee too, there is also a process whereby our teams talk to one another regularly and reconcile this. In addition to that, there was the recent establishment of the PSA Finance Committee, which we focused on during the negotiations and the conversations, the meetings around drafting the PSA. So if there are concerns, then those items will be elevated to that Finance Committee for discussion, resolution, debate, deliberation, all those things that will move us to that next piece in our relationship.
Okay.
Can I also add one thing? There are two separate things that came, well, three actually. The renewed relationship between the medical college and the hospital. There's a joint hire committee in which from the NGH side, Dr. Bullock is the chair, is our CMO. And then as Dr. Blackledge just mentioned, the PSA Finance Committee, which she is the chair on the NGH side, and the CFO, Connie, from Meharry and Rowland, Dr. Johnson, are on that committee. And Lori Donnell, who's in the audience. Thank you.
If I may, I see that this is a 2-year agreement. And I know that there's been a bit of a conflict between leadership in the two entities that it appears is being worked out and worked through. In the event there's a change of leadership over at Meharry, or there's change of leadership here, what methods are in place, mechanisms are in place to ensure that personalities don't get in the mix of process so that we don't end up back where we were before this moment?
So to answer that question, I think what we would hope is if there's a change in leadership here, that the board would pick an individual that would operate in integrity and uphold that established relationship, as well as if Meharry Medical College went a different direction in their leadership, selecting an individual that is willing to work with the hospital, I believe would be key. To talk about the 2 year, the 2 year is to coincide with the lease. And there are current discussions about a lease extension, but we couldn't make a document that lasted the lease of the building, which is why this is a 2 year term.
So thank you for that. I just want to, and I'm sorry, I'm the new guy, but I want to say this. I just hope that we would be very intentional about not allowing personalities to get in front of process, and that we would hold to the mission of both the hospital and the college for the sake of people.
I would say that is the sentiment of the current board.
Wonderful.
I just want to go on record to commend the leadership of the hospital as well as Meharry's leadership. I happen to know how hard they worked. The idea that you pulled this off, whereas in the previous 5 years it couldn't be done, is just a testament to the engagement and the collaborative spirit. So it was beautiful to watch. Thank you.
Can I just ask one more question, just for the sake of my own information? And so you are serving as interim. Is there conversations about permanent, not necessarily permanent as it relates to you, but there has to be some leadership moving forward. And so where are we with that conversation? And if that's for another meeting,
No, I'm just making, we have a CEO search committee, and I'll give a report later, but the brief thing is there's a committee. We are hiring an executive search firm to assist, and there is an ongoing process to select a permanent CEO.
Go ahead. All right. Any further comments? I would like to take the liberty of just recognizing our partners in the room from Meharry. So if you are from Meharry, would you please stand up? We'd like to thank you for your time, your partnership, and all the work you put in. So thank you. All right, well, this has been a long time coming, as many of us around the room have seen. It has been expeditiously accomplished by our current leadership. And to your point, sir, this board has leaned in hard and supported both organizations. And it is up to us to make sure that this doesn't derail. So, we count on each of you sitting around this table and everybody in this room to make this happen. All the relationships and the clinics, all the individuals who are leading this hospital in every interaction with Meharry or any other third-party service provider, the reputational, I think the professionalism in that will supersede in our reputation. So we really need to focus on that, and I know everyone here is committed to doing that. So I think we are definitely on the right path. So with that, it gives me great pleasure to ask for a motion to to approve our professional services agreement with Meharry.
Motion to approve.
Second.
All right. No further discussion. All in favor?
Aye.
Aye. Motion passes. Thank you again. And I've heard from many in both the mayor's office and in our community as a whole, people are very, very pleased that this is happening. We were able to have a conversation with another stakeholder hospital who had just nothing but positive things to say about this renewed level of engagement and partnership. So it's just fostering all kinds of positive public sentiment. So it just very exciting times. New business, KPMG presentation. So Dr. Blackledge, would you like to kick things off?
Good afternoon. Thank you, Board Chair. As we invite our KPMG team members, I want to share that I stepped into this role back in February. Understanding and going through my assessment at that time, made a decision to come forth and say we need some assistance. Was able to gain alignment with stakeholders, brought KPMG in. We heard from the board perspective, we actually heard from KPMG here in the room probably 2 or 3 months ago. And so we've spent a period of 90 days making 99 plus, and you can't make it up, 99 plus changes within our finance arena that has led to some cost control improvement and improvement in the accuracy of our financial statements. So I just want to introduce Hillary and Chris and bring them forward to introduce themselves again and then to share the outcomes. And this will be the end of this point in our project. So this will be the end of that. So I just want to make sure I share that. I'm very appreciative of the work that occurred. I'm very appreciative of how we aligned, debate, deliberate, move things forward, and also have a few laughs along the way. Thank you.
Thank you, Dr. Blackledge. So good afternoon, and thank you all for having us. Again, my name is Hillary Simic. I'm a partner with KPMG, and I have Chris Dixon, a director on our team, with me today. So what we wanted to do is give you an update on our project. As Dr. Blackledge mentioned, we are coming to a close, and our real focus on this project was improving the financial reporting process and really making a sustainable process along the way. So on the timeline, Dr. Blackledge covered the first part of it already, and our project really kicked off in May. During this time, we came in and really wanted to understand the current state, helped with some month-end close, and during that time, what we really found was the prior practices just didn't meet industry standards. So we identified quite a few improvements and started implementing those improvements along the way. For August, we continued with that same work, really this time focusing on year end, getting prepared for the audit, and then implementing those process improvements and finalizing our roadmap that'll go onward through September. So after this month and after we leave, the NGH accounting and finance team is well prepared to kind of take things forward, stabilize some of the new processes or improvements that we've put in place, and then implement some of the new ones that they've already started to identify and want to improve with. You can go to the next slide. As part of our project, we committed to you, to Dr. Blackledge, and to NGH that we would deliver certain documents and tools. So we've delivered several different policies and procedures, and this really just standardizes the practices that the accounting and finance team follow. In collaboration with the team, we've either revamped or created new reconciliations and tools, which allows the company to have better visibility and better control over the financial data. Along the way, we got new accounting and finance team members at NGH that have really stepped up, and we've seen a lot of, with the policies and the tools, more internal communication between the team and a lot of collaboration between parties. So with all of this collectively, it's really building the foundation for creating a more sustainable financial reporting process and equipping the leaders, yourselves, Dr. Blackledge, Dr. Elders, with more reliable data to make decisions going forward. So with that, I'll bring up Chris and he'll talk a little bit more around some of the specific improvements that we've implemented.
Thank you, Hillary, and thank you everyone in the room. I'm Chris Dixon. It's good to be with you again. We chatted about 2 months ago, and on this slide, as it appeared then, I joked at the time that KPMG was going to take a bit of a medical approach to how we examined and executed this project. We would look at problems and try to determine what those problems and symptoms, underlying causes were, and ideally prescribe a solution. And that's where we're at today. We're at a point in the process where, as Hillary said, we've had enough time to observe and discuss with the teams what some of our observations are, and then start to plan and implement solutions. And there's a few stories I guess I'd like to tell that are part of these process improvements we've made along the way. I know the slide's a little small, so I'll talk about these out loud. The first one really relates to invoicing. That was a problem we discussed when we were here 2 months ago, and it was a problem where the hospital was behind on accruals and paying their vendors timely. So one of the big focus areas of this project from KPMG was that. And what I'll mention, when we didn't quantify it a few months ago, but really there was a backlog of multiple thousands of invoices. And as a result of that, that causes delay in processing and delay in time. So what we did is set out to provide a tool and process to the hospital that would allow for vendor-specific accruals for the largest of vendors, and then outreach to those vendors, which improves communication, cuts down the time of waiting to receive those invoices, and helps with processing them more timely. As a result of that, if we just look at the timeline, really since Dr. Blackledge arrived, February in this year, there was $27 million of outstanding payables. Fast forward to when we had that first month meeting at the end of June, and after we started in May, those payables were down to 20 million. And as of today, they're at 13 million. So you see there's improvement and there's momentum as these processes start to take place. The next item I wanted to point out, I think it's pretty important, is revenue. It's the top line. The reason we focused here is because what we realized coming in is that there were, what I'll say, were non-existent processes as it related to considering and communicating with the revenue cycle management team how you get from their gross numbers to the accounting net numbers for revenue. It's a calculation that's typically done, and there was a lot of estimates and judgments being made before that really weren't up to industry standards. So what we did is we have a tool that we've worked with other clients on, and is pretty typical around hospitals here in the US and how this calculation's done. And we work with the hospital to implement that tool here locally to help with this calculation and to help get better data on the income statement for revenue, as well as better data on the balance sheet for what's the receivables that are outstanding at a given point in time. The next item that I'll mention is what I'll call deferred reconciliations and analyses. Typically what we expect is as a company or hospital goes through its life cycle, it's performing regular reconciliations and analyses over key accounts. These were largely being held off to year end at the hospital, and that is not only, I guess, abnormal as we would state of some of the other hospitals we've seen, but it's also not really in accordance with some of the accounting principles. So what we've done is implement monthly reconciliations and monthly processes, which ultimately, as stakeholders sit here in the audience, leads to better, more timely information on a monthly basis rather than having true-ups at the end of the year. The last item I'll mention quickly on this slide relates to payroll and HR. There were concerns, and we discussed them on the last meeting, around situations where there would be either employee transfers or terminations, and those communications from HR would not always get processed timely by accounting and payroll. So what we've implemented are processes and checklists by which ultimately there's more reliable and timely communication between those two departments, and again, leading to better financial results and more reliable financial results. Now, these are a few stories that we plucked, but if we go to the next slide, this is a chart we looked at a couple months ago, and it's the totality of process improvements that we talked about with Nashville General. And as Dr. Blackledge joked, we call it our 99 process improvements. There's 90, so it doesn't foot perfectly. But at the end of the day, these are 90 areas across the different verticals, which I'll read out loud that you probably can't see from there, but it's invoice processing, capital expenditures, patient revenue and AR, which I mentioned, payroll, and then quite a few other areas that collectively add up but are minor for purposes of presentation. So across these areas, we had a bunch of individual observations, and what we noted and what was really helpful that Hillary alluded to just a moment ago is we had new employees in the finance and accounting department who were coming in right as the time we were implementing some of these improvements, and they really embraced them and ran with them. And as such, we got to see a lot of these improvements just during our 3 months here already start to be implemented. So with all that said, I'll transition to the last slide that has a quote of what we as Hillary and I and KPMG really feel is the point or the inflection point the hospital's at right now from their accounting and finance department, and is just meant to summarize everything I've discussed. So I'll read it out loud. It says, over the course of the last 3 months, Nashville General Hospital embraced process improvements, both those recommended by KPMG and those developed internally, that have increased and enhanced transparency and consistency in internal communications, as I mentioned. These improvements, coupled with new leadership and a collective tone at the top, have strengthened the hospital's ability to produce more accurate financial statements and improved record keeping. And this last line is probably one of the more important ones, and it's, as a result, the hospital is well positioned for a timely and efficient audit for this next year, as well as generally better and more timely reporting to stakeholders. And what I wanted to leave with is a thought. I've come to visit the hospital quite a few times. I focus at KPMG on healthcare companies, so I fly around the US. And in walking in here quite a few times, I've noticed the signage outside, and there's one quote, a beacon of care and compassion, that stuck with me. And that's how I felt KPMG has been treated since we've been here. We've really teamed well with folks in the room, including Dr. Blackledge and Ray and others. And it's been really, truly an honor to come here and be able to help the hospital in this meaningful way. And I thank you all for both your time and your consideration of KPMG in this. Thank you. And happy to answer any questions, of course.
On behalf of our board, I just want to also thank you. I know you've received a lot of, positive comments from your both finance department and the board back to me personally, but the work you guys have done has been tremendous. We really are thankful that you were able to come in and help us rise to a new level. And obviously, it sounds like everybody's made a new friend. And so you guys are, I think, pretty close to as well. Don't you have a physical presence here in a building? So look forward to continued friendship, but also, other ways that we can continue to learn from KPMG and your expertise in this area and subject matter. We appreciate your time away from your families, as many of you have traveled in, and the diligence to just being here. So thank you very much for that.
We appreciate that. Thank you.
Thank you. Next item on the agenda is a reflection of progress from Dr. Elders and Dr. Blackledge.
And I'll go to the podium if y'all don't mind. And so you do have a separate packet for this presentation. It's not in the folded. And so, one, I want to thank you for the opportunity to just give an intimate insight on our progress. And so this says a reflection of progress February to June. And so it's a look back and an outlook on our strategies. Do I have a clicker? Thank you. Okay, y'all already know the mission, so I really want to just talk about where we were at the beginning of this year, so the beginning of January. Metro Internal Audit was investigating the hospital for allegations of waste, fraud, and non-adherence to board bylaws for hospital contracts. We had the retirement of our long-term CFO, reports of nepotism, lack of fairness, and favoritism in the hospital environment, and a fractured work culture. There was an outcry from employees to board members in the city, non-existent work relationships with Meharry Medical College, the mayor's office, and other community stakeholders. As we mentioned previously, there was an expired professional services agreement with Meharry that had been expired for 2 years, installed contractual negotiations, which over a period, I'll say, of 5 to 8 years. At that time, we were at 16 chief executive leaders with 117 middle management positions. So what did we do? First, let's talk about people and stewardship. So salaries and administrative costs are the highest expense for healthcare organizations. We initiated a reduction of costly contract services and contract labor expenses. Through leadership restructuring, we reduced our chief executive positions from 16 to 6, and we also reduced our middle management positions from 117 to 67. We closed the operations performance department, which was equivalent to 6 positions, and reduced the employee count of our CHIN division, leading to a leaner leadership team with a more streamlined operational oversight. And that was the organizational chart as of June the 3rd. Next slide. Thank you. This slide displays the themes underlying our core process changes from March through August. So enhanced transparency and communication, renewed accountability with a culture of servant leadership, fostering a cultural change throughout leadership and the frontline staff. We increased operational efficiency through a focus on costs and expense management, and we also worked to optimize our technology with a special focus on Cerner and our staffing resources. These changes enhanced our employee engagement, empowerment with an overall focus on customer and employee satisfaction. So process look back again. So culture of accountability. Our chief and other key job descriptions have been rewritten and acknowledged by each leader. We restructured our department head meetings and our daily leadership huddle. We have fostered transparent communication through monthly town halls and management by walking around. And we have a new campaign where the employees can scan a QR code for a private or public answer directly from me and our leadership team. So there's also been a revision of our organization's contract process with leadership education and training. There are renewed partnerships with which we boxed that in red with the mayor's office, metro government departments, Meharry Medical College, the Nashville General Hospital Foundation, and key community stakeholders. We have also successfully remediated all Metro internal audit findings and revised our revenue growth strategy, which we will detail later in the finance slides. Thank you. So getting our culture right is critical to achieving Nashville General Hospital's vision in the future. And so as you all just approved the PSA, which was worked and done within about 4 months, I currently am having monthly meetings with Dr. Hildreth, who is the president of Meharry Medical College. They have been encouraging to me, and he is a great leader to learn from. From an employee relations standpoint, with our SEIU leaders, we are focused on biweekly meetings with department leaders and then monthly meetings with administration. That helps with the employee relations and resolving issues with our employees timely. We have promoted communication across all levels of the organization with a focus on exceptional customer service, patient-centered care, and accountability to both our internal and external customers. Our board relations, I hope you all will agree, have improved through regular touch base with board members and the executive leadership team. The executive leadership team know they all can talk to you freely. There are no qualms about that, and I believe that the board as well as our executive leadership team have taken advantage of that ability. Management by walking around, which has yielded 80% participation rate for our most recent employee engagement survey, which is a record for this organization in I believe my tenure here and the tenure of quite a few others. We've also performed a human resource performance assessment and action plan to address our gaps in HR functions. Next slide, yeah. So this is an organizational efficiency roadmap. This was a result of our work stream too. So KPMG not only worked on our financial infrastructure, but we did have an arm that looked at our workplace efficiency and culture. And we did have a chief retreat where this came out. And we kind of titled this as Do Now, Do Next, Do Later. It's our roadmap. So Do Now is really looking at our customer service campaign. We are revising our code of conduct, our Nashville General Hospital values, which includes a refresh of our employee handbook, dress code, and behavior of employee policy. We are memorializing and standardizing critical organizational processes. There's also a focus on leadership response expectations, meeting protocol, and ground rules for positive work culture and environment. We are working on our hospital's onboarding and offboarding processes to include exit interviews and a revised position control process and committee to manage salary expenses across all levels of the organization. This will maintain and strengthen Nashville General Hospital's key service lines to promote preventative care and chronic disease management. Due next is 4 to 6 months, and that's the rollout of budget changes at the department level, department leadership level, organization talent review and development. We'll continue executing our culture plan and rebranding campaign, which rebranding our organizational culture is what we define by that. The UKG implementation will be completed around January 1. That payroll cycle is slated for January 2026. That will give us technology tools for both payroll and human resource platforms and combine them into one. Due later, we will update our hospital strategic plan with performance management metrics and rollout. And I mean update. Right now, we're currently executing the plan that we have in place and looking at our growth strategies, but we plan to do an update with board involvement in the future. With the UKG tool, we'll also be able to do 360 evaluations for all leadership and frontline staff. With that, there'll be a frontline level organization talent review with a continued focus on customer service. The next slide. Sorry. Okay, so our June year-end look back. And so we have 10 growth markers, which is clinic appointments, our no-show rate, patient reschedules, referrals, surgical volume, our inpatient census, our ER volume, rehab therapy utilization, diagnostic imaging services, and vendor management and cost control. So these are our growth markers that we are strongly working on to enhance the success of the organization. So if you look at where we were at June year end, so our admissions, we were at a 3.75% to the good. Our emergency department visits, they are still about 2.6% down, but I do want to just give a shout out to the emergency department leadership team as they have really worked on that door to bedtime with an average of 4 minutes currently. And that was a lot of work that went into that. Our clinic visits are up, but we do still have Bordeaux in our Metro Center location that's in that tally. And so our clinic visits are up at June year end. And then just a shout out to the perioperative services team for increasing our inpatient and outpatient surgery cases in partnership with our surgeons. That big variance in the cardiac cath lab is due to our changes in the cardiology program and the absence of an interventional cardiologist, which we now have 3 general cardiologists, and we have an interventional cardiologist slated to start in November, and we have a work group that is working on our cardiology service line to be ready, and so we are looking at that to be addressed within the next fiscal year or this fiscal year that we're currently in. Our shrink to grow, and so we initiated, our salary expense, we initiated our shrink to grow right around the end of March. Urgent care reduction on weekends at our Bordeaux location was about $400,000. Our contract services reduction was 1.78, and then our contract labor reduction was 7.2 million, and then our salary expense reduction and the closure of OPC was about 4.5. And then, of course, most of you know, except for our new board members, that we did close our Midtown location, which was operating at a $1.5 million loss. So if you look at the total annualized savings of 14.752, which had we not taken any steps and not done anything, we would still be incurring those expenses. So now I will turn it over to Dr. Blackledge to provide a further detail on our financial strategies, economics, accountability, and financial culture. Dr. Blackledge.
Thank you, Dr. You need to. All right. Good afternoon again, and I'm excited to share. You've heard a little bit about our journey. I came before this board in March and made a commitment during the finance segment that we were going to focus on economics, accountability, and culture. So a couple of themes that I've heard since we've been in this room is sustainable practices, implementing improvements, effective, efficient, new methodology for our accounts receivables, which I would commonly call it a model, and that allows us to apply a value on our AR consistently and regularly, and to be able to share that documentation. Rise to a new level, we call that elevation. So as we talk about our people, and keep in mind this is from the finance side, so UKG Ultimate Chronos Group, we had this group to come in, work with us, take our employee data, just for all of the employees in-house, and look at what the opportunities are. So when we talk about people from a finance standpoint, there are 3 different buckets that at the end of the day, we determined that we were going to focus on. We decided to focus on these 3. So improving our schedule adherence. What are the patterns of punches and edits, time clock rounding? Those are the things that cost an organization. So when we think about cost control and we began our program and our initiatives, you know, this is an area where you don't start out right away, right? Because we want to deal with the big costs that Dr. Elders covered earlier. So that's one area for our future that we will continue to focus on. Reducing turnover. Turnover has a significant cost to any organization. It's funny that our highest turnover is from the newest employees. So understanding that, our intent to focus on that and reduce that by X% to yield about $500,000. Minimizing our compliance risk. This is really cost avoidance. One of the things that we've spoken about is de-risking. And from our perspective, from the finance group, de-risking is significant for our organization. So when you think about fatigued employees, accidents, these are the things that happen within hospitals. And so we want to make sure that we're focused on those items that can cause us some kind of dollar value to the negative or a risk. If we talk about our processes, and I always use velocity with respect to time, right? So there's a certain amount of velocity, a certain amount of time, then there's quality that goes along with this piece. We go to the next slide. And so from a process standpoint, is controlling these items and implementing the processes timely, effectively, and efficiently. And so 2 that I really want to focus on are governance protocols. So contract submissions. For one, standardizing that procedure has been significant for our organization to provide us a lift in understanding what we are doing, what we intend to do, why we are doing it, what is going to be the cost of that organization, and more importantly, in finance, how do we classify that? You heard us talking a little bit earlier about, is it a lease? Is it a software? I mean, how do we use and what is our intent for this product or service? How do we maintain a clear trail of the activity that has occurred as it relates to a contract? How do we centralize this communication? And so we have a contract module. All those are loaded into the contract module. One of the things that we haven't spoken about quite yet is post this meeting, there were 4 contracts today that came before. The finance team, along with the contracts team, that team will be meeting to make sure everything is hardwired. And so we're not playing catch up when we're trying to close the books to figure out what we did during the month of August. Second thing I want to talk about is KPMG, and you've heard a lot from that, but the ability to de-risk the organization, to have a model that gives us the confidence in how we value the accounts receivable, the money that's due us from the service providers where we provide care to their members. That's essential and that's important to the organization. Having a checklist, and again, it's the capacity to gain what I would call that efficiency with speed. Had we not brought KPMG in, the things that we have been able to do over the last 90 days or so would have taken us an extended period of time. So we're talking about 2 years or 3 years, which brings the risk to the organization. Dr. Elder spoke about work stream 2 with KPMG, so I will not go into details there. The chief job descriptions were revised, meetings were restructured. The biggest focus now as we look forward to is education and training. So that could occur in our department leaders meetings, town hall meetings. Our intent as we move forward is to focus on small groups, engagement surveys, and then to continue our process improvement further. We can go to the next slide. And so where are we going? The next 3 slides, we're going to really talk and walk through where we started, month in February, what we have done, year in June, and where we are and where we ended July. But where we're going right here, $323 million. So we ended FY25 at $294 million, just to set the tone so there is awareness. But we're heading to 323, so how will we get there? Go to the next slide. First, let's talk about February. In February, we were looking at $22.7 million in terms of negative balance in terms of our revenue. At the end of that month, we were down by $16 million. So when we think about February, not a good month. Not a good month. Change fund balance, $16 million loss. Now, let's go to June. Next slide. All right, we're there. If we changed nothing about our performance from February to June, we could have easily been at a $24 million loss. But fortunately, NGH made some very dynamic changes that positioned us for a better outcome, reducing our February negative balance by half by the time we closed the year in June. So for those of us that were on this journey, whether you were in the room, whether you were observing the work, whether you supported, whether you sent a note of encouragement, whether you had something that wasn't so good to say during that time, this, at the end of the day, was a significant achievement for the organization. I want to go and just talk about where we are moving forward to. So when we think about our outlook strategies, there are 6 areas that we want to make sure that we apply significant energy to, significant understanding, significant focus. And so what does that mean for us? It looks like teams, it looks like working to prepare for the future. And those 6 items are our hospital admissions, our emergency room visits, our clinic visits, surgery cases, and then the cath lab. All right. So we can go to the next slide. As we move into this new fiscal year, so let's talk about July's performance. We achieved the highest patient volumes in 6 of the 15 key metric areas. So when you look at this slide and you look at the metric areas, they're soft green, highlighted. And then to the right, you have the dark green. The dark green represents the areas for that month that achieved the highest volume over a period of 6 to 7 months. So that was significant for us. This serves as an indicator that as we came into the month of July, we're moving in the right direction. And Ray shared earlier during the month of July, for those in the finance meeting, I think the actual revenue achievement was $26 million for that particular month. And keep in mind that we had came off months where we missed our revenue target by $4 million or so. Let's move to the next slide. So when we think about growth and how we have positioned ourselves, we heard the markers earlier. From the markers, the 10 markers, there are 6 actual metrics that we are hyper-focused on. And from there, we have 12 initiatives. The initiatives are to the left. To the right is what I would call the rationale, the golden logic. I'm just going to target a few of those items. So looking into items that have high margin services based on our patient needs, ensuring that we have the right policies in place, increasing our surgical case volume, looking at our CT imaging. What do our missed procedures and appointments look like from a revenue leakage standpoint? Can we go back and capture those? And what is our protocol to do so, to drive more patient volume into our organization? Can we fill those gaps? Can we focus on cardiology services based on what our patient population needs? Positioning ourselves to achieve that target and to, as we did in the past, shrink. This time we're focused on the growth part. So we did the shrinking from February through June. Our focus now is on the growing. So I want to pause right there. And one of the things that I do want to share is that the KPMG deck, we did not have it out before you. We will work with Janet to make sure that we submit a copy to you. Other than that, thank you. Happy to answer any questions, but I will turn it back over to Dr. Elders. Thank you.
So our last slide, I just want to talk about our continued progress over the next 300 days. And so building on our rich legacy of operating for the last 135 years, our commitment to the hospital, our employees, and the Nashville community, it is stronger than ever. And so through these efforts, we aim to streamline our operations, modernize our infrastructure, continue to cultivate a culture of transparency while also empowering our dedicated team to provide exceptional patient care and foster lasting community relationships for generations to come. The last slide. I want to especially thank each one of our board members for your service and the support that you've provided to the hospital and the city of Nashville. So thank you for your service. We'll take any questions.
First of all, I want to thank the two of you for leading this institution to a much better place. You and your teams have done an amazing job, and it started on day one. And I want to thank you. One of the things that would be ideal for the hospital is to see if there's a strategy to communicate to the community that we're a different institution. Is there a strategy to do something like that?
Well, we'll be working on that. And so just, we couldn't do it earlier. So there will be an invitation to each of you and some key community stakeholders for a public PSA signing in partnership with Mayor O'Connell on September the 3rd. Those invitations will go out tomorrow. We couldn't send them out prior to the approval, but now that we have official approval for the board, that will be the start of that launch to share with the community that we are a different organization.
I would be remiss looking at your strategic July outcomes, which I appreciate this graphic because it kind of emboldens me to say that in July you have some velocity with what you're doing. It's pretty apparent that the processes you guys have put in place are working. But I will also mention that we should continue to look at deliveries.
Absolutely.
Thank you.
And can I make one last, are there any other questions? I'd like to make one last comment and just thank the Nashville General Hospital employees. It's been a journey over this last 6 months. They have hung in there. We are making great strides, and I just appreciate them very much. So thank you.
If I may, Dr. Elders, just want to say thank you for not jumping ship. Thank you for sticking this out. Thank you.
All right. That was a great report. I think it was very helpful for those of us who have lived the journey. It feels like a lifetime, but it has been a really short amount of time. And to see that what you and everyone here has accomplished is just truly tremendous. And again, couldn't have done it. I know a lot of us on the board, all of us that are on committees and have leaned in and come to different events. Thank you as well. And I'm so excited about where this is headed to. So next up is the medical staff reports. Dr. Miller.
First, the bylaws, and what has happened with the bylaws is in a similar vein to the professional services agreement, in that after a long period of time, a final document is very, very close. So there were a couple of tweaks that Metro Legal wanted to make. They're not significant, but I would expect that at our next board meeting, we will have a bylaws to look at and review and likely approve. The next thing is that we have several new staff members. Dr. Stanley Lee is being put forward for nephrology. Dr. Cassandra Wheeler is a nurse practitioner for nephrology. Dr. Carlton Adams is being proposed for general and vascular surgery. And Dr. Brunetto for emergency medicine. Dr. Alan Portillo for internal medicine. Dr. Dustin Taylor for dermatology. Dr. Sarah Woods for emergency medicine. Dr. Fakhriya Nazi for emergency medicine. Dr. Christina Sadlow in internal medicine. Christina Kirkpatrick, nurse practitioner for emergency medicine. Keisha Ashmead, internal medicine, nurse practitioner. Jamie Bryan, MD, MPH in emergency medicine. Dawn Bristol, a PA in emergency medicine. Ryan Johnson, DO, emergency medicine. Kevin Kearney, emergency medicine. And Dr. Teresa Kahn, nurse practitioner in cardiology. All of those have been reviewed by their service chiefs and have been recommended for appointment to the medical staff.
I just have one quick question with Sarah Woods. You said she's an RN, right? Nurse practitioner or a doctor? It was just, I must have misheard. I wanted to make sure. RN, okay. On page 16/32.
Yeah, she's an RN,
Yes.
Family nurse practitioner.
Okay. Mm-hmm. Thank you.
We need a motion to approve the.
So moved.
Sorry. Is there a second?
Second.
And any further discussion? Seeing none, all in favor?
Aye.
All right, motion approves. All right. Thank you, Dr. Miller. Next up is our CEO Performance and Search Committee report, Mr. Espinal.
Thank you, Madam Chair. The chair of the board appointed a CEO search committee to conduct a search for the hospital's next CEO. as an update to the board. That committee met several times, determined that we needed to do a procurement process, a public procurement process, in order to select a firm that will assist us in our search, an executive search firm. On July 24th, we received 10 bids from potential firms who've expressed interest to work with us on that, and Metro Procurement is leading a process to select the firm. There's a scoring process, and that's all being guided by Metro Procurement. The update is that is currently underway. I don't have a timeline yet as to when that process will conclude, but the board should know that's underway, and we are moving as expeditiously as possible. And what will happen is that procurement group will recommend to the CEO search committee the selection of a search firm. That committee will then pass that along to the board for approval. And once the board approves a contract with an executive search firm, we have put in the procurement documents that we expect work on the CEO search to continue to begin immediately once that contract is signed. So we are moving carefully but expeditiously, and that is the status of the CEO search committee.
Thank you. Any questions for Mr. Escobar? Any questions for Mr. Escobar?
Is there a meeting of the committee next week, or?
Yes, we have, because we have been, the RFP is out, the committee has not met in a couple of months, but we are meeting again on Wednesday. There won't be much of an update other than that, but the last committee meeting, there were some questions from Metro Legal, and Metro Legal will be present to advise us on the questions that were asked, in addition to general discussion about the process, again with guidance from Metro Legal about how we're going to conduct some strategies and things for us to talk about in terms of conducting the CEO search itself, in particular how to do that consistent with Open Meetings Act requirements and other legal requirements we have as a public body. But yes, we are meeting on Wednesday next week.
Okay, thank you for that. Next up is Dr. Enzure with Finance Committee and Dr. Blackledge.
Good afternoon again, everyone. So I will present a synopsis of 4 contracts that came to the Finance Committee for review. The first one is the Aquis for Air Handler Unit refurbishment. The proposed cost is $479,000. It's not in the current contract, and 3 bids were received. This is a contract to
The chair recognizes Derek Smith. Sorry.
Okay. Legal counsel would just ask or recommend that category B under item 9 on the agenda. I think that's actually the place currently at the July report before the contracts.
Is Dr. Blackledge? Yeah, we jumped to contracts and instead it's a recommendation by our legal counsel to make sure that we go in order. So I think that we were on contracts, and we'll go ahead and have the July reports and then utilization trends.
Thank you. We'll proceed with
the committee is certainly able to speak to that too, but puts us back on the agenda. Okay. Thank you.
No worries.
Welcome, Finance Chair. First meeting.
okay.
Okay. Hello, everyone. Going to go through the July financials real quickly. We'll start with the statistics, which we've already covered pretty thoroughly, including deliveries, which I'm glad that was pointed out by a board member, because that is a pretty special area and great improvement there. So I'm just going to go straight to the income statement page. And the left and the right side on this are the same because this is our first fiscal year. So I'm going to go through about 4 things. First thing I'm going to go to is actually down towards the bottom where you see net income of $7,891,000 on a budget of $217,000, which looks really good, and it is. But that is primarily driven by kind of floating back up towards the top in the other revenue section, kind of in the middle, where you see additional state funding of $11,262,000 on a budget of $1,791,000. That is for some additional funding that we received that was unbudgeted, which was a very pleasant surprise, and we are very happy to have that. And that those funds are primarily going to be used towards paying down and directly towards our accounts payable, which we'll talk about here in a minute further. So that's what that is about, and it was unbudgeted this year because we did not receive it last year, and so that's why it was not budgeted for this year. So first, on net patient revenue, just above where that section is, you see net patient revenue of $4,600,000 on a budget of $5,700,000, so $1 million under budget. That has to do a lot with what KPMG has already talked about the new methodology that we've adopted relative to the past, and so that's kind of that is not industry standards what we've been doing up to now, and so that transition to this new methodology, which is part of the reason there, how we get our revenue deductions and our allowance for bad debt. The second one is just below that in the other revenue section under city subsidy. We have a $6,062,000 on a budget of $5,062,000. So that's exactly $1 million above budget, which is directly tied to the KPMG project. The corresponding expense associated with that is down in the expense section under contract services. So we have the $1 million going in for revenue. We have $1 million in expense. Therefore, it's a wash in terms of impact on our financials. The next area, second area, is contract services. And again, we're still in expenses, $1,650,000 on a budget of $914,000. That has, well, I've already mentioned that. That is the KPMG cost. Just above that, in pharmacy, you see pharmacy at $1,143,000 on a budget of $699,000. That is directly associated with some efforts or additional efforts in pharmacy related to the specialty pharmacy for medications that are a lot higher cost. And so there's a concerted effort to grow that area. And so we have corresponding revenue that we expect to come in as well. So that has grown significantly, and we should probably be talking about that in future months. And then the final area is under leases and rentals, a little bit lower. We have $2,000,001 of actual expenses on a budget of 1.2. Again, that has to do with the KPMG. We're going through kind of a review or extensive review of our leases, and we had approximately 10 leases that were improperly accounted for. And so we now have them under proper accounting, and so this is a true up of those leases to make sure they're properly accounted for. And so those are the main areas. Any questions on the income statement? Okay, on the next page, real briefly on the balance sheet, just want to point out the accounts payable, about middle of the page there, $16,000,005 compared to last month of 17.3. There's a lot of discussion on that. We've back in February of 27 million, really concerted efforts to pay that down and get that back to normal levels. So that is the only item from there. Any questions? Okay, thank you.
Sorry, dropped my pen. Next up is the utilization trend for the Bordeaux Imaging Center. Mr. Tim Farmer. He is our Director of Radiology. Thank you.
Yeah, my name's Tim Farmer, Director of Radiology. I appreciate you having me. I just learned that we don't have the slides for this, so it's in the packet, so we can go through the packet. Before, I know the title is utilization, but I want to kind of back up a little bit for the new members of the board and kind of establish how we got to where we're at with the imaging center. It is our 1-year anniversary this month. In March of 2022, we submitted a certificate of need for an imaging center in North Nashville to the Tennessee Health Facility Commission. That certificate was granted and construction started in March of 2022 on the imaging center. During that construction period, we met 3 separate inspections, 2 progress inspections by the state and 1 final inspection by the state. In July of 2024, the final inspection was completed and passed, and we received our license to operate as an independent diagnostic facility on August the 7th of 2024. We've seen our first patient August the 8th of 2024. At the same time, we submitted to the American College of Radiology for accreditation, and we started our payer enrollment process. In order to submit to the American College of Radiology for accreditation, which is required by the payers in order to be enrolled, you have to be an active center, you have to have a license. So everything had to line up on August the 8th for us to do that. On your next slide, you'll see the American College of Radiology accreditation was achieved for mammo, December of 2024, MRI and CT, June of 2025, and ultrasound, I apologize, not on there. It was received in February of 2025. That is a 3-year accreditation, meaning that we meet the highest level of standard for imaging as well as safety. And again, it is required by the payers for us to be ACR accredited. In order to be ACR accredited, you have to see patients. It's kind of the catch-22 with an imaging center. On your next slide, we get to the actual utilization. This is through July of 2025. August, September, October, November of 2024 was our accreditation period. That's why that volume is a little lower, as we're trying to achieve that accreditation and go through the enrollment process. July, we end up about, I think, I can't see my wrong writing. For August, we'll end up a little bit over 200. That's where we're on track of right now. Exams a little bit over 200. Your next slide is the aging report. I will say this report is a little busy, but when we open an imaging center, again, we have to have patients in order to be accredited. We have to be accredited in order to be enrolled with the payers, and we're competing for a couple of items. We're competing for market share, we're competing with referrals, and we're trying to get the enrollment piece done. The majority of the payers on this aging report have been resubmitted for payment. The largest one being the workman's comp, and I'll touch on that a little bit towards the end of why that is the amount that it is. But again, this is new volume. This is not volume that we shifted from the facility to the imaging center. These are new referrals that were going elsewhere in Davidson County. We did not shift volume after 2025. We did 2024 in order to achieve the accreditation. 2025, we did not. Next page is your revenue by modality. This is your actual utilization report. On these types of reports, you like to look at the MRI. That is the top modality that generates the most revenue. This gives us our monthly utilization. This gives us our yearly to date utilization, our cost per procedure, our payments, and the payments per procedure, which will go up as the aging report goes down. Your next.
Sure, I quite understand the numbers. So if you look at MRI, we had charges of $91,000.
Correct.
And And then payments of $6,300.
Again, we're going through the process of payer enrollment. So there are some payers that we are not completely enrolled with. We do not have effective dates with.
And so out of that $91,000, we only got $119?
That's payment per procedure.
Payment per procedure.
Yeah, and that goes up as your aging goes down. As more revenue comes in, the cost of the procedure goes up.
Okay, so there were 53 procedures. Okay.
Yeah, if I could just follow up on that, the year-to-date column is sort of the same one that I had the question about MRI. So year-to-date, there's about $300,000 in charges, and we've collected $20,000 in payments, which my question was kind of the same as Dr. Miller's, which seems like a relatively low. Yeah, and I understand that there's an aging, and so though payments can be expected for those charges, but can you just, I mean, do we think that's going to catch up for MRI as a modality?
I think it will catch up, but we got to keep one thing in mind. Charges and actual bills are two different items.
Right.
We can charge one amount, but the insurance company may pay 125% of Medicare. So the charges are always going to be a little higher than your actual payment.
Right.
It's just the way it is on.
So
But I do believe it will catch up as the insurance companies enroll, as we start to reclassify. We had a lot of modifiers that were missing, location not on the portal. This is on the payer side. So we get the denials and we work the denials and come back in and resubmit them. It will catch up, but it will never meet the charges.
Yeah, I get that. The charges are, nobody pays charges. So I think, well, what would be helpful in terms of data, because this is really interesting and informative, I mean, I think helpful information, is you have the aging report by payer and then the revenue by modality. If there was a chart that had aging report by modality, then I think, we could have better insight into it. So, anyway, my suggestion is that this is great information. If you can add that, then we can't compare the aging by payer to the revenue by modality. So that would be useful.
We can request that from the billing company.
I have a question. Looking at this, I'm assuming based off of the buckets, because I look at these reports myself every day. The biggest bucket is your workman's comp. So I'm assuming getting multi-plan credential would help you with the collections, and also getting the third MCO plan with United Healthcare.
It would help us. The workman comp on this particular line item is true Metro IOD workman's comp.
Okay.
And I don't want to use luck of the draw. They went through an upgrade of their system at the same time we were starting to bill for them. So that's why you see that large amount. That has all been resubmitted, all approved. It is working through starting this month. They had issues on their side that we were off location, et cetera, but that is working.
And that's injured on duty for Metro, correct? Okay.
Correct.
All right.
The pending payers, how long do you think that will take? And are we taking patients from those payers now?
So on this last slide, the payer enrollment slide, we have an executed section of the payers that are executed fully enrolled in, and then we have the pending side. The pending side are pending counter signatures from the payers. We hope to have that back 30 to 60 days. That sits in their side of the house. They will give us an effective date at that point, and we will move forward with doing patients. To your question, do we see patients that have these types of insurance? If it is a referral from outside of this facility, then we will see that patient. Because nothing kills the referral process quicker than me telling a referring physician we can't see your patient. We're, again, back up, we're competing for market. We're competing for referrals. If I go out here and get a physician to send us a patient and then he learns that we couldn't do that patient, it's probably going to be the last time I see that patient.
So looking at that a little closer, we actually only have one of the MCOs right now.
Correct.
And we're pending on two of the three, which is substantial. And then, of course, with the number one procedure being MRIs, is that more from a Medicare population?
Correct.
So these numbers actually could shift once you get the enrollment. So you could start doing more mammograms, you could start doing ultrasounds, et cetera, et cetera. Okay.
The payers, the managed care is one of the hurdles that we're trying to get over at the moment. And again, it's waiting on countersign. The last page is service lines additions. I actually call it established referral base. Again, the referral base that we have is from outside the facility. We could have easily drum up volume by shifting it. We didn't want to go that route. We do bi-monthly screenings with Tennessee Breast and Service for mammos. That's been very successful. We've been doing that since October. We have a relationship with Merrick Medical. We have a relationship since June with Faith Family over off Charlotte. We do whole body MRIs, lung screenings, and calcium scorings for a company in the Gulch called Next Health. August, we started echocardiogram services on Wednesdays for the cardiologists. And the big one, in August, we launched our physician portal. The physician portal allows the referring physicians to see their images and reports. It also gives them a text message when that patient has completed the process. That one feature, every time I talk to a physician, is what they want. That one feature right there will help move these needles. And the other one, and these are no order, we were designated as the Imaging Center for Metro ILD back in February. So police officers, fire department, school teachers, all are coming to the Imaging Center.
Quick question regarding your point about the physician portal. How long is the turnaround for that? Because I see that's, as you described, that's a great advantage. I've actually never heard of that before, where you have the convenience to be able to go and look. Oftentimes we have to make phone calls, get the reports faxed over, and that can take, manpower and time.
We can have you loaded in 24 hours.
So the reads on MRIs and that kind of thing are...
So the reads, routine reads are read within 24 hours. Stats are turned around within 1 hour.
But you're saying you can actually look at the images right away here. Okay, I like that.
It is verified by the tech. You have access to the images.
Okay, outstanding.
And since this report, we have referral agreements from Impact Sports and Medicine, Orthopedic, Matthew Walker Comprehensive Health, and the Wellness Senior Center located down the street.
With that said, I'm really, I see all of this list. My goodness, getting the UHC and the WellPoint on board is going to be hypercritical. Because this is an absolute growth center for the hospital. Absolute. It's exciting because I've noticed your trend that you were getting over 150, 160, 200. You said,
200.
Well, you
on
said
target for 200 this month.
I think this thing could snowball, and they're all being seen in. Are these at Bordeaux?
4007 Clarksville Highway, Bordeaux.
Yeah, very familiar with the area. Thank you.
Can you give us a sense of what thinking about what the trajectory is of what is the capacity for this facility, and how much of the capacity does 200 a month represent?
So full capacity for that facility would be 30,000 exams a year. 2,500 a month.
One follow-up. So do we have long-term or interim goals in terms of that metric as to how much of the capacity of the facility we want to try to achieve over the next 3 months, 6 months, year, 2 years, and a plan to do that?
We have a marketing plan to do it. I'm out every Friday speaking to referring physicians. I got 2 of them tomorrow. I've got one on Thursday that we're doing the portal training on. We are trying to get to 1,500 a month. We get to 1,500 a month, and at that point, the next couple hundred is not hard to get to. Again, I agree. It is an imaging center that will snowball. It is out right outside of Raleigh. We have a couple of advantages. The portal is advantage. Our turnaround times are advantage. I'm gonna go into selling now. All reports turned around within 24 hours, stats within 1 hour, access to images immediately, paging when the scans are done.
Is there any incentive for a Metro employee to have imaging done there versus a provider that they may have in another healthcare system?
So for the Metro employees, we do waive the copay. So that's the incentive there.
And do you think Metro employees are aware of that?
We've done a few Metro employees. I can tell you that, you know, the police department, fire department, and school teachers are very aware of it. And we've had return customers that came in as an ILD and has came back as a patient.
It would seem like it would be a big advantage having had to have imaging done in the past with the Metro, with the no copay, of course, but the parking, right? There's ample parking over there. There's the time in which you're getting the images back to their physician. I mean, I just think I didn't know that. That's great.
You know, we take same-day walk-ins for MR, CT, ultrasound, X-ray, same-day walk-ins. We obtain pre-certs for you. We turn pre-certs around within 1 hour. We have a couple of referrals for orthopedics that utilize that, sports orthopedics.
Tim, one last quick question. The ultrasound, is that vascular ultrasound, or is that just general, like gallbladders and that kind of thing?
It's a vascular system.
Excellent.
We do have to achieve the accreditation in vascular, but we have to get to that volume level first. Okay. General, we already have. The vascular, we have to achieve.
What was the name of the organization? You said Impact Sports, Matthew Walker, what was the other one?
Centerwell Senior Primary Care. Matthew Walker, Impact Sports are the three that came through after this report was submitted.
Is there a plan to maybe reach out to 50 Ford since they're putting a new facility?
50 Ford in Madison?
No, well, they're moving to Bordeaux. Yeah.
So
they're building a building right now.
Yeah. So we've already kind of targeted 50 Ford, but they were in Madison, so we're moving to Bordeaux, and we'd be more than happy to go talk with them.
Oh, and Metro schools, since it's football season, with these CT scans.
So the orthopedic, the orthopedic that we have that is providing is the orthopedic for the Metro schools. So we do see that them athletes. Also, we see Austin P athletes. So we have that route.
Thank you very much. Very informative. It's exciting to see what you guys are doing out there, and look forward to getting updates from you. Thank you. Next up is Dr. Enzere with kind of summation of our capital expenditure requests and contracts.
So we have four contracts. The first one is the Akis Air Handler Unit refurbishment. Proposed cost is $479,000. 3 bids have been received. This is basically the system to help us with the air around parts of the hospital, with purification, and also it prevents leak. The second one is the agility. Okay, one at a time. Okay.
We'll go ahead and answer any questions and on the first contract. So does anybody have any questions? All right.
I move approval of the first contract.
Is there a second?
Second.
Any further discussion? Seeing none, all in favor?
Aye.
Aye. Motion passes. Second contract.
Okay. Second contract, Agility Health for mattress replacement. Basically, we want to replace about 140 mattresses. They've really, they're really old, and I think the recommendation is to replace them. The cost is $318,000. 3 bids have been received, so need a motion for approval.
Do we have a motion to approve?
Any question?
Is there a second? Any discussion? All in favor? Motion passes. Next contract.
The third contract, Geringer, has to do with sterilization in the operating room for equipment. It's a preventive maintenance for these sterilizers, 3 years. Total amount is $221,000. Need approval as well.
Is there a second? Any further discussion? All in favor?
Aye.
Motion passes.
And then the last one is the collection company for the diagnostic imaging center. You heard all about the diagnostic imaging center. So the plan is, if they'll send a bill for whatever is not paid for, and we understand they will send they will try to send the bill 3 times, and then after that it goes to collection, and it's a 70-30 split with the collection agency. Also need approval for this.
I had a question about this, and that it's convention in hospital collection that if you have some communication and engagement with a patient, they don't go out for collection. Or if you have a patient that is completely unable to pay, that you may settle that in a way. I mean, what does this process look like in this collection process?
We'll ask Mr. Foreman to come back up and discuss any questions.
So the collection process, the patient would receive a statement 30 days, 60 days, 90 days, and then on the 121st day, they will be notified that they are going to collections. They have the opportunity at that point to make a phone call and to work out a payment plan, or we can move them out of collections at that point. As I stated earlier, we do take self-pay patients at this facility. While we do not anticipate a lot in accounts receivable, it is a good practice to have some form of a collection.
There's no communication other than a statement?
There's no communication between the 30 and the 90. There was communication with the 121. They're asked to call the billing company, or they can call the facility itself. We can establish a payment process with them. I'll also say that if they make a good faith payment throughout the 30, 60, 90s, that has established a payment process, they do not go to collection at that point. These are only for accounts that are completely inactive.
Yeah. I guess that, David Esquivel raised this at the Finance Committee. We deal with a population that generally doesn't have the ability to come up with the money for an MRI or whatever. I think we need a process that's a little more benevolent than just a statement and you're out for collection.
So we do have a process for low paid, low income we do have payment processes that we can set up on the front end. This is for individuals who have completed the testing and the account has gone completely dead. It gives us one avenue to pursue it.
And I'm happy to jump in with you, Tim, on that piece. So, hey, I'm happy to jump in with Tim on that piece. What Tim intentions is to build a platform. This is a separate platform away from the hospital. There is a benevolent inroads. We have policies and procedures that govern our collection activities. Now, I haven't asked Tim this, but I'm sure the answer. If Tim chooses to modify, if we're saying we believe that there is a better response if you make a phone call, text messaging, other avenues and tools are available or should be available.
They are. We're actually working to put text messaging in place of the statements. Patients will receive text messaging. They have the right ability to respond, pay over the internet, and it is a flexible policy. We can move it in any direction we need to move it in.
But the crux of the matter is establishing the support and the infrastructure for the diagnostic imaging center off campus, because the patient population at that center, we need, as you've shared, we need to be able to drive growth, drive volume. If you look in the look back and outlook deck, that's the top line item. We intend to grow that area, so we want to have the right level of supporting tools that we can't just transfer from the hospital to that existing domain. And so that's really the crux of it. But to respond to your question and to hear additional feedback, if there is a difference of opinion about a phone call versus a text message versus a letter, Tim has the bandwidth to work with the organization to modify that and change that based on the response rate. Right. And so all of that ties together.
Just a quick question. So let's say we approve the contract and ultimately the process at this juncture. Do we have the ability, I'm guessing we do, to come back, let's say in a year, evaluate if it becomes a different level of irritation and or a way we don't want to continue to do business? At that point, we could pivot and change the dates, change the way the process, if you will, behind the scenes. Is that accurate?
And if Tim needs to cover his out clause,
Yes, it's a 90-day out clause. It's a 1-year agreement, renewable for 1 year, that can be modified at any time throughout the year.
Excellent.
I did raise questions about this in the Finance Committee, and I think, my own view is that if we are operating this kind of a facility and a person has the ability to pay, and we've already rendered the service, they ought to pay for the service. So, that is a baseline. And what Dr. Miller has said, and the concern that I share, which is that I think I articulated as a reputational, because I have seen in this field very aggressive collection efforts on behalf of healthcare facilities become a reputational problem. When you go after people who absolutely have no ability to pay, and we're not dealing with this volume, but there are hospitals and providers who file hundreds of lawsuits. And, we ought to be careful, again, from a decency standpoint, but a reputational standpoint as well. So in general, I think the sentiment that I have, that is, again, my own sentiment, not the board, is that we ought to be, because we are controlling who we send to collections and what we do, we should be mindful of that in general. I have a specific, because I read the agreement, I noticed that the agreement requires the collection agency to seek permission from us before they file a lawsuit, which I think is standard in the industry.
It is, but we wanted to make sure that was in that agreement.
Correct. So that's a great check. And I guess further encouragement for you and the team is, if you identify a person who we know has the resources to pay and is deciding they just don't want to pay, I don't have a problem initiating litigation to get paid what we're owed because we provided the service. But I would say we ought to look very closely at that. And when the collection agency comes to us and says, we haven't gotten any money, make sure that we are proceeding down the legal path and having that impact on someone that we're doing that in situations where it's merited. Because I guess sort of a question is, at the end of the day, we don't expect a lot of return on this, I don't think, right? I mean, this is you get pennies on the dollar for this. So again, keeping that in mind, which is we're not talking about a significant source of revenue, but we're talking about potentially significant risk to the organization in terms of what we're out there doing, and we ought to balance all of that and trust that you have all that in mind when you're doing this.
And I'd add another modifier, which is also a moderate amount of intimidation of our patient population.
Thank you, Board, for your comments. Anything else? Okay.
We need a motion.
Yes, we need a motion to approve. Do we have a motion to approve? Is there a second? All right. Any further discussion? All in favor? Aye. Motion passes. Next up is the interim CEO's report. Dr. Elders.
You have a brief, just, I always like to share some sunshine. So we have the B and Daisy Award. I won't belabor since we did the look back. There's just several updates in which we've already covered. You'll get an invitation for the public PSA signing tomorrow in your inbox. We are working with Meharry Medical College on a clinical research center and parking garage upgrades, which is a testament to the renewed partnership. We're also working with our Metro departments. We have collaborations with the Nashville Innovation Alliance, the Metro Information Technology Services, as well as Metro Finance. I do want to point out that you'll see more contracts in regard to the HVAC system, but that is a total of the sum of which we reported as urgent at the last meeting. So when you hear it again, this one was $500,000. There was a total of 1.3 that we need to get the HVAC into a better spot. And so you'll see some of those. And then thank you for the mattress replacement as well as the refurbishment of the units. Lastly, the compensation salary review, HMS Valuation Partners has been selected. They are a law firm, and they're scheduled to report back to the board around the September board meeting. If there's a change in that, we'll let you know. We've provided all of our data to them, and we're waiting on their analysis. But that was a vendor that was provided by our law contact as well. And that's really all I have. Thank you so much.
Thank you very much. I have no comments. I think there's been a lot said today. So with that, I appreciate your time. Exciting board meeting, and look forward to seeing some of you at the signing with our mayor and obviously our partner Meharry. So thank you. I will entertain a motion to adjourn. Second? Oh.
This has been a service of the Metro Nashville Network. If you would like to see this presentation again, or for more information on this and other programs, visit nashville.gov.